just joining, welcome. And we're really delighted to have you with us here today. Thanks so much for being a participant in Invest4Health's first public workshop. It's very exciting for us to be here at this moment because this is the biggest, most comprehensive public presentation we've made to date of Invest4Health's work. We are reaching the midterm of the project right now, and this is an opportunity for us to tell you a bit about what we've achieved and all the plans that we have going forward, and how we hope we can actually involve other actors, other regions, potentially municipalities, and so on, in our work in the next 18 months. So first, to introduce myself, my name is Alison Mawson. I'm a program manager at EuroHealthNet. And if you're not familiar with EuroHealthNet, we are a non-for-profit network based in Brussels, and we represent national public health institutes, some ministries of health, local and regional authorities, civil society actors, research centers, academics. It's really quite a broad mix. But what brings us together is a focus on reducing health inequalities within and between European countries and trying to act on the determinants of health. And we're delighted to be a part of this consortium, leading the work around operational readiness. So today I'm going to be chairing our discussion and trying to move us along and keep us on schedule. I'll do the best I can because there is a lot to cover. And on the next slide, we're going to show you our agenda for the day. On the slide after that, sorry. So great. Yes, just a short welcome from us. Then we're going to be going into the first part of the agenda, a presentation of the Invest4Health project. You'll be hearing a bit more about the concept animating the project, this smart capacitating investment, how we have come to define that, and examples of that. Then we'll be looking at compatible finance models and considerations for stakeholder governance of smart capacitating investment approaches. The next session will be around setting the scene. We have a high-level panel where we could say that the three perspectives roughly represent practitioners, investors, and citizens/patients. And we're going to be looking at this question of why we need innovative financing models. And we hope for this to be a very interactive debate. You may have noticed that we're all here today in meeting format, not in webinar format. So you have the right to unmute yourself, to interact with us on the same playing field as any one of the speakers. And we hope that you will do that. Then we'll have a short break, and after we come to our session on why to engage with Invest4Health, we'll be telling you a bit more about what available expertise and resources we have on hand. And my colleague Theo will be telling you more about the launch of the Invest4Health Open Call, which is, again, available to different actors that might want to do something similar to what our current pilot sites have been doing in their contexts. And in the final session, we'll hear from our pilot sites, or test beds, as we've called them, which are located in Galicia in Spain, in North Rhine-Westphalia in Germany, Wales, Western Wales within the UK, and Skåne region in Sweden. And then we'll just have a very short next steps and closing remarks to make sure that you know how you can continue to be involved if you are so inclined. I mentioned already, if you go back, David, I mentioned already that this is meeting format. Just a few notes of housekeeping around that. Please do keep yourself muted if you're not speaking. And we are recording so that this session could be available to people who might not have been able to join us today. We had quite a few registrations, but I think it seems that some people have not been able to make it. So we want to make sure that they're able to access this information after. Just usual good behavior. I think we've been doing these online meetings for a long time now. And we would already like to welcome you to introduce yourselves, who you are, the organization you represent, and any experience that you may have to date with innovative investing models, with creative resourcing of health promotion. So anything you can share with us in the chat would be wonderful. My colleague Emmy Weller will be monitoring that closely, and my colleague David Hargett will be behind the scenes making sure that everything runs smoothly. So thanks so much to both of them for their support, and thanks to all the consortium partners who are here. I'd like to know if Katarina is here from Region Skåne, if she's available to say a few words of welcome.
Yes, I'm here, but I can't get my camera to run.
Okay. Yeah.
So.
But we hear you well.
Yes. I will just say a few words, and welcome to this midterm workshop. And time flies. is already halfway in the project. And today we are all expect an interest and dialogue during the workshop. And I can say something about Region Skåne. We are very interested in improving being a better healthcare provider by working with promotion and prevention. And it's a very important way that the project Invest4Health can give us an opportunity to try out some innovative paths. Invest4Health is one of many initiatives with which Region Skåne is engaged in to explore new perspectives of the healthcare system together with different stakeholders. And this is a really important issue for the future, working together with others. And I'm very sorry about my camera. I don't know what has happened. But I'm here. Thank
Well, it's
you.
great. Thank you. It's great to have you with us. And what's important is to be able to hear indeed your insights into why Region Skåne has taken on this ambitious project and what you hope to achieve with it. And we'll be looking forward to hearing more later as well during the testbed section. So thanks so much for your words of welcome. And now I'd like to go ahead and formally kick off part one of our discussion, which is going to be around setting the context for Invest4Health and why we're doing this project. So this will be presented by Joanna Lane, who's the founder and managing director of Stichting Health Cluster Net in the Netherlands. And she's going to be directly passing the baton. You'll have to hear less from me. Directly passing the baton to the other three colleagues who are going to be presenting our research outputs to date, who will be Jacob, Balash, and Bengt. So Jo, thank you for being with us. And the floor is yours.
Thank you very much, Alison. I've been told it's always good to use analogies or metaphors when we're talking about some of the things we're talking about today. So I'll try to do that a couple of times at least. And I'm starting off by saying health systems are a lot like oil tankers. It takes a long time to change direction. Infrastructure is always stressed and the crews do constant maintenance. And that's kind of like health systems. And in the past 20 years, they've faced two major disruptions, the financial and economic crises in the early 2000s, and then the very, very unexpected COVID-19 pandemic. And along with aging populations, these events have really accelerated demand and perversely a decline in capacity. So, for example, by 2030, Europe is expected to be short of 4 million healthcare workers. And even if overall economic growth is forecasted to grow at a slower rate over the coming decades, health spending is projected to actually outstrip both expected growth in the overall economy and in government revenues. And at the same time, other public sectors will suffer cuts to baseline expenditure to provide the fiscal space that healthcare and also long-term care needs, even with current service design. And that service design is increasingly not fit for purpose. Next slide. Actually, next slide. I've moved through that one. Right, okay. Reimagining things. OECD say we actually need smart spending to strengthen health systems resilience, and that includes healthy populations. The pandemic showed that we can do things differently, and while prevention is more present in policy language, the problem remains that embedded patterns of demand still lock funds into costly treatment and care. Health systems in this way function primarily as repair shops. They may be replacing or shrinking these repair shops with new deployment models, such as agile regional service networks, is part of the answer, but that would need due emphasis on and investment in health promotion and disease prevention. After all, over 75% of our healthcare costs relate to chronic diseases, and much of that cost is preventable. Next slide. If we go and look at spending on prevention during and just after the pandemic, you can see that in 2020 and 2021, spending surged by an average of 50%, and that was for resources for testing, tracing, surveillance, and so on. But that increase was short-lived, and spending on prevention contracted by about 20% in 2022. And as a result, the share of total health spending allocated to prevention was more than 4%, just more than 4% in 2022, slightly up from 2019. And yet, a health economist would tell you that health promotion and disease prevention is or can be cost effective, that prevention will save the health service money in the long term, and that the benefits of prevention reach far beyond the health system. And I know this because I've done work which found that municipalities and local government, whether they're spending on something labelled as prevention or not labelled as prevention, often spend far more than health systems on prevention. And there's a fundamental challenge here that prevention needs to be seen as an investment, and it needs to be designed and financed within an investment paradigm. Next slide. And this brings me to the final point that I want to make, and that is the financing solution that this project is working on is smart capacitating investment. Now, that term originated in a working group of a high-level task force back in 2017. Task force was shared by Romana Prodi, Steve Wright, who's online with me, and I were involved in that task force. And the task force focused on boosting investment in social infrastructure. So that encompassed health, long-term care, social housing, and education. And it also built on capacitation through social investment, which had research that had been going on for over 10 years. And from that, we created the idea that maybe smart capacitating investment could be an incentivizing and sustainable financing mechanism to boost investment within and between the sectors that I've just mentioned. And so getting funded for this project was a timely opportunity to really develop and test the idea of smart capacitating investment. And at this point, then I'm going to pass on to Jacob as the next speaker. He's actually stepping in for Professor Rhiannon Tudor-Edwards, and he's going to be telling you a bit more about smart capacitating investment as a concept and how it's being tested.
Thank you very much, Joe. And yeah, thank you for the introduction and the handover, as I am not Professor Edwards. So thank you very much for that. So my name is Jacob Davis. I'm part of the project team working primarily on work packages 2 and 4 at this stage of the project, very much the conceptualization stage of the project, where we're working to develop definitions of SCI and its constituent parts that we can then use throughout the project and into our translation into real world practice. So next slide, please. So this working definition of SCI has taken several iterations and is very much condensed from the initial one we had, because we had so many ideas, and it's a very complex sort of thing. As Joe's already alluded to, there's a lot of things going at play here. But this is the current working definition that we're really pleased to share with you all. So smart capacitating investment involves unconventional investments, and these can be either financial or non-financial. And this is the key note here in health promotion and disease prevention. So yeah, this is a common theme we're going to touch upon throughout the project, and Joe has already alluded to some of the reasons why these are so needed in the current landscape. These investments may be made by social impact investors, philanthropists, and public authorities with the aim of enhancing individual and community capacity for healthier behaviours, while addressing health determinants and promoting sustainable change, and also aiming to reduce health inequalities. These investments may consist of entirely new resources entering a system, or they can also be the reallocation of existing resources, but then targeted towards enhancing health promotion and disease prevention. Next slide, please. So in developing this definition, I can talk about some of the work that we've done done in sort of leading up to this development. So we conducted, as part of work package 2 in our project, a scoping review of SCI examples in the literature. So we were looking to see what's already out there, what data can we already find to sort of inform our reasoning and inform our sort of definition of smart capacitating investment. And the next few slides are going to talk about some of the results from that review. Oh, sorry, could I jump back to the next one? Sorry, I know I said next slide. Thank you. So this is a SCI flowchart. So this is something that was produced by colleagues in work package 2. And this is a really sort of helpful visual tool, because I appreciate there's a lot of words, there's a lot of terminology being thrown at you today. So this is a really helpful visual tool, both for those seeking investment, but I guess also for investors as well to understand the landscape and sort of what SCI framework works within. So at the top level, we see, coming back to the definition, we have the financial or non-financial resources invested within. I'm not going to go through every example, but the next step down from this then is what outcome are investors looking to achieve by inputting their resources. So we can see, looking at the blue column, for example, we can see social impact investors who are aiming for a financial, so aiming to recoup some of their initial financial money or investment in, but also seeing evidence of a social impact or social return on investment. So this may be through like a predetermined outcome from which payment is then triggered, for example, through social impact bonds, social outcomes contracting. But in the green column, we can see this may be purely they're only looking for a social return on investment, and the financial return on investment is a secondary priority and a bonus if it comes in. So this just sort of lays out some of the framework for smart capacitating investments. Now I'll move on to the next slide, please. Thank you very much. So when we're talking about disease prevention and health promotion, I think a really easy way to sort of frame this within is the framework of the prevention pyramid. So this is something that colleagues working within healthcare may already be aware of, but it's just a way for us to sort of disaggregate prevention across a spectrum. So like when I first joined the project, to me, prevention just meant stopping something from happening at all. Whereas I've now learned there's a lot more, as many things are in life, it's a lot more sort of detailed, a lot more structured than that. So I'll briefly talk over this, but we can see primary prevention across these first three segments is primarily looking to prevent conditions from occurring in the first place. And we achieve this typically by modifying risk factors all the way from a population level up into individual levels in sort of patients to have a targeted or an increased risk of obtaining a disease. We then move a step up further where we can talk about secondary prevention, which is targeting like the earlier detection and diagnosis of conditions. So then we can more effectively treat conditions at the outset and sort of prevent longer term conditions and sequelae from generating an impact in people's lives further. And then at the tertiary stage is where someone already has a condition and they're sort of living with it, but it's how we can help them to actively manage their condition and reduce the impact it's having on their everyday life. So prevention spans all the way across from modifying population risk all the way to helping and targeting improving individuals living with a condition to live better and have greater well-being. Next slide, please. So another output from the review is, so we've talked about some of the SCI models in the flowchart, and we've talked about prevention in the prevention pyramid. So we've combined them in this heat map matrix here. And as we did our scope and review of examples, I think we found around 80 examples from both the published literature and then also from the grey literature. And we've represented these here. So social impact bonds were the most common SCI model identified. This was largely driven by a really strong evidence base coming out of the Oxford Government Outcomes Lab, a really helpful online resource. And yeah, we identified several studies of relevance in this project. When we're talking the level of the prevention, primary prevention was the most common prevention level addressed in a lot of these conditions. Secondary prevention and then tertiary prevention sort of less common, but they were still identified examples, which is really nice that we were able to sort of span that whole spectrum. Next slide, please. So in populating all those, I think it's now a good time to sort of give some examples of what we did identify in the scoping review. So the first one is Projeto Familia, coming out of Portugal. And this was a social impact bond that raised around 400,000 euros from both a health promotion foundation and then a private bank. So there were two key investors here. And the goal was to reduce the institutionalization rate of young children in a region in Portugal. This was a persisting problem that had significant societal costs in terms of the cost of institutionalization and breaking up families. The goal of the social impact bond that activated payment was that 60% of children were aimed to stay with their families after the intervention was administered. Following in the evaluation, the social impact bond had a 91% success rate in keeping children with their families. So out of 180 children, only 17 were institutionalized. This reduction in institutionalization also translated to a 90% cost saving rate compared to those who had to go to institutionalization. And then 99% of initial investor investment was reimbursed. So this is a really positive example where we're seeing the generation of social as well as financial return on investment. Can I move to the next slide, please? Thank you very much. So this is another very similar project, and I put this in as a bit of a contrast to show that we had the initial sort of smaller regional scale example with the social impact bond in the first example, but this example from Finland moves on to a very large scale cross municipality intervention that received a total of €5 million funding from across 8 different Finnish organizations. And these organizations were set across different sectors, but they were able to sort of induce investor and stakeholder buy-in to run this social impact bond. Similarly, this was around sort of interventions targeting children, and again, going into sort of institutionalization and foster care. The project was successful and 600 young people were enrolled, and there was evidenced well-being improvements in the children participating in the intervention, and €4 million in performance bonuses were paid to date. And this project is still on running, so it'll be a really interesting one to sort of follow up and see if there's a final evaluation. And I'll move on to the final example, please. So we've had 2 examples with the social impact bonds of outward investment coming into a system. And this is an example of where there was actual no outward investment and rather a repurposing of resources that were already contained within a system. So this is a example coming out of a West London sort of healthcare regional area. And this was sort of putting in place a model of social prescribing. So social prescribing is something that's sort of taken off in the UK in the last few years, where we sort of in primary care and other non-healthcare areas, we're prescribing and we're sort of signposting patients who traditionally probably would have just been told to sit on a waiting list for some other medical care. We're then signposting them to non-medical service to help them actively manage their conditions. In this case, they were targeting the frail elderly in the population who had been presenting more and more frequently with more and more complex cases and living with multi-morbidities, and as a result, taking up several contacts with primary and secondary care. So the social prescribing model was put in place to sort of reduce some of the burden on both of those services. As previously mentioned, this is sort of there was no outward investment received. It was very much just repurposing the own funds within the region toward this model of prevention, disease prevention and health promotion. At the end of the study trial period, there was a social return on investment of £2.85 generated for every £1 invested. And we can see considerable resource cost savings here through the reduction of GP contacts as well as hospital admissions. So yeah, we can see there's cost savings in this case can be sort of seen as a proxy for the return on investment in the financial sense. And I'll move on to the final slide, please. Thank you very much. So the last slide I'm going to end on today. So we've talked about some examples and we talked about some of the definitions, but the review in Work Package 2 went a little further to incorporate this element of realism. So realism is a framework where we look to understand what works, for whom does it work, and in what contexts does it work. So again, adding to the complexity of SCIs and the landscape around it, we pooled together the information from the review and also used that with expert stakeholder and expert investor interviews that we're going to hear about from a colleague Balash later on, to sort of see, okay, we've got these examples, but why are they working? Who are they working for? And in what context do we see the effective implementation of SCIs? So we've pulled together some common barriers and facilitators that we did identify through this pooling of information under this realist informed framework. So some common barriers that hindered the implementation of SCIs were multi-sectoral collaboration can be undermined when partner contributions are not recognized or valued, and where one partner holds more power than another. Managing multiple stakeholder expectations and ensuring consistent and effective delivery across large regional areas can be challenging due to variation in local priorities and contexts. And some of the facilitators that I'll mention sort of actively address some of these conditions arising. Failure to engage and build trust with the local population, community organizations, and local authorities can hinder effective delivery. So I think these are they're quite common and they're quite sort of understandable barriers, but these can be overcome through sort of engaging with the local institutions, engaging particularly in the political context as well, as this does sort of underpin a lot of this one. It's definitely talking around health financing. And these can help support implementation by sort of working to develop this buy-in. Also, being able to evidence the effectiveness of your given intervention or initiative through potentially a pilot study, we found was helpful in increasing stakeholder support and investor willingness to invest, as they can see, okay, this has a track record, I'm willing to put my money against this. And finally, related to this is the regular monitoring and reporting of performance indicators to not just investors, but also to the stakeholders who are working and involved in running the intervention, can sort of foster a positive culture and progress things and keep things working towards that final goal. So I believe that's the end of my slides. So I'm now going to pass on to my colleague, Balázs, who's going to discuss a little further with you. So thank you very much for your time.
Morning, everyone. Thank you very much. So my name is Balázs Babarci. I'm working at Syria Research Institute, and we are working on investment and finance models. So we can go to the next slide. And the objective of this work is to put in practice the frameworks that Jacob has just presented. So having established a conceptual framework, we are working towards tailor-made investment and finance models in the current test beds of the project, and obviously beyond. So we are looking forward to working with new test beds and potentially developing new models as well. And the emphasis here is on tailor-made because, as Jacob has alluded to, there are a lot of opportunities, a lot of different investment models, but each of them obviously have their advantages and drawbacks, and it very much depends on the local context which one can work. And even beyond, maybe we can construct a model which has never been developed or applied before, but using the conceptual elements that we have identified through the scoping review, we can develop and build together new and flexible models of investment and finance within the SCI framework. So that's the idea. And if we move forward with the slide, it is a 4-step process that we have laid down. So first of all, visualizing stakeholders and their relationships. There is a lot of work currently ongoing within the project of understanding actually which stakeholders are involved in the interventions and public health projects that the testbeds are offering. In investment and finance models, obviously, we are focusing on the top 3 or 4 players who are most relevant from an investment and finance model viewpoint. So a little bit simplifying and aggregating stakeholder models to focus on those who will decide actually how the investment and finance model may be set up. And once this is done, we are defining a value proposition for these key stakeholders, and would like to understand again in cooperation with the test regions how the intervention that is proposed can make value for those key stakeholders, which linking back to what Jacob has just said, can establish the case for moving forward and secure the political buy-in and also the economic incentives that could make such a project work on the long run. So the third step is designing investment and finance model options. As I mentioned, very much tailor-made. So based on what we have found in the literature, but moving beyond if necessary. And the fourth step is testing investment readiness. Once there is a selected model, again linking back to the realist evaluation that Jacob has just mentioned, and looking at the barriers which could which could cause an intervention, an otherwise successful intervention to derail or to fail. We are looking at what is needed for the testbeds to make it implementable and to make it successful on the long run. So next slide, please. Thank you. I'm going to go through all these 4 steps in a little bit more detail. So step 1 is stakeholder visualization to create a common understanding, again, in conjunction, in cooperation with the regions that we are working. And I mentioned that we are focusing on those stakeholders with possibly the most impact on the setup of an investment and finance model. And these are usually some sort of a commissioner who is again, usually a public body who is interested in promoting population health and increasing the health level of the population in question, and is at some sense willing to make efforts, financial or non-financial, but efforts and investments to secure a higher level of health in the given population. And we are also counting on external investors. This is not necessarily the case that there is an external investor, but usually when we are talking about SCI, we expect someone from outside of the healthcare system to come in. This can be another branch of government, so local authorities, education, housing, or other sectors, but this can also be private organizations, usually not-for-profit. So as in some of the examples mentioned earlier by Jacob, there are social impact bonds and obviously funds financing social investment, social impact bonds. But this can even be commercial banks or other types of organizations. And obviously there is the target group for which the benefits, the health benefits have to materialize. And there may be other stakeholders. Of course, this is only a very simplified picture, and we are using it very flexibly. So this is only one example. We modify it according to the setup and the context of the testbeds that we are working with. Next slide, please.
Just to jump in very quickly, Balázs, and say we'll have to move a bit more quickly through each of the slides because we started a bit late. So my apologies for starting late, but we'll need to go a little bit faster slide by slide if that's all right. So
understood. Okay.
Thank you.
So the next step is a value matrix, which we use to design the value proposition. So as you see, there are a lot of different types of value which actually public health project may generate. These are some of the most common ones. There might be extra ones, again, beyond this. As I mentioned, this is always very much tailor-made and put into the local context. But these are very common elements of value, and these can be financial and non-financial. Again, this can make sense for either a commissioner or an investor. And what we have to find is a common ground between, if we are working with an external investor, what the external investor would like to have out of this project, and what the commissioner, who is usually responsible for the health of the target population, would like to have out of this project. And if we can identify the value elements which the project can deliver to both of these actors, and additionally the other stakeholders that are relevant in the project, we can find a common ground based on which we can develop an investment model, and then we can go to the next slide. And step 3, and you have already seen this slide because this is the flowchart of SCI models that Jacob presented earlier, so I will not stay long at this. Only mention that there are, as you see, a lot of different possibilities. Building on these examples, we can construct an investment and finance model which fits the value proposition that is there in the given intervention and the given local context that we are working with. So we don't need to find any of those and just use it as a black box, but we can have an inspiration from any of those and set up a tailor-made model based on the value proposition that the project has for each of the key stakeholders. And we can go to the next slide, which is a typology of these investment and finance models. So this is a detailed description of how it works. Once we build it, we can give such an overview detailing the scope, the level of and nature of the partnership between the stakeholders, how the investment contract actually works, and how the risk is allocated between the participating organizations, how the outcomes are measured, and how they are linked to the payments, which is the feasibility and the scalability of the project. These are all very important and fundamental aspects of the model that we look at each of them individually, and this helps us create a comprehensive model. And next slide, please. As I mentioned, there is also a test of feasibility and readiness in the context of the chosen model. So this is what you can currently see is only a work in progress. This may be refined, but we are working on the most important aspects of testbed readiness, which may determine how successful it will be. And linking back again to the realist approach that Jacob mentioned before me, this could allow us to be prepared for the implementation of the selected investment and finance model. So I think this is all from me. And yeah, it's just a recap. So to make it short, I'm handing over to Bengt.
Thank you, Balázs. My name is Bengt Stavendov. I'm from Innovation Skåne. We are, say, the innovation company that's linked to Region Skåne, the coordinator of the project. And I will discuss a bit more in detail some of the, say, barriers and enablers that have been mentioned when we talk about multi-stage stakeholders coming together to try to address a challenge. At least in the media in Sweden, there are quite a lot of noise around challenges in the society right now. And when we start to discuss solutions, we often come back to the solution is to collaborate in between different authorities and administrations. That's easily said, and as you understood as well, there are, say, issues related to financing, to whether we should view this as investments or costs, etc. But I will discuss a bit more further then what does it take to collaborate as well. So next slide, please. The good side of SCI is that it brings stakeholders together, and bringing stakeholders together to address a challenge or to implement an intervention That means that you get a multidisciplinary setup where it's then maybe easier to take a more holistic view on the problem and on the target group, and hopefully then come up to solutions that are very effective and with the shared purpose that we should develop health and enablers for individuals to take care of the health themselves. Next, please. But is it that easy? Because when we bring stakeholders together, they come from the different setups, and they have their interests, and those interests could be conflicting or at least competing. There could also be say, friction among stakeholders, because quite a lot of these organizations, stakeholders, they have a history together from earlier on. And a difficult thing, as we know, is always when we need to share resources, we need to agree on who should finance what. And we also know that there are quite a lot of barriers when it comes to sharing data, which is a must in order to create transparency and trust in these types of collaborative setups. So that there is a need for readiness before we implement the interventions in a collaborative approach. We have to be ready to do that. And readiness, as mentioned, for example, by Balázs, it means that we have to understand how we take care of the multi-stakeholders. We have to understand how we do co-governance when we are going to develop things and take the decisions on investments and resource sharing, etc. Next, please. So if we start with how we manage the multi-stakeholder setup, one perspective of this was mentioned by Balázs, mainly in the financial, in the investment part of the collaborative setup. But it's more than that. We really have to understand who are the stakeholders that we have to involve, which are the stakeholders that could contribute with different types of competencies or solutions, and what's the common purpose, the shared purpose, and what's the purpose for each individual stakeholder. Next, please. This is not that easy, because we collaborate with different reasons. That's to ensure that we have information and transparency on what we are doing together. We should co-create new solutions and new way of working, and we should take decisions when it comes to co-governance. And each of the different stakeholders could have different interests, could have different perspectives on this. But we still have to understand how we develop a readiness so that we are not hindered by different interests, and we really could join into the shared purpose itself. Next, please. And the third perspective of this is then to how to develop the common value proposition, or how to develop the implementation and the intervention around the shared purpose. For each of these perspectives, there are toolboxes, and by the illustrations to the right, I've indicated different examples of this. And these are, say, toolboxes that we have partly developed or at least adapted to our context, and that we include in the type of training platforms that we deliver from the project, and that we test and evaluate in relation to our test beds. Next, please.
Bengt, I'm afraid I'm going to have to rush you along just a bit more. So we're going into the panel's time now. So I apologize for this, because it's not your fault as the final one. But thanks for coming through these last ones a bit faster.
Okay. A key objective with the Invest4Health project is to involve citizens, and we view citizens as a stakeholder in more or less any type of setup related to prevention and health promotion. We make use of stakeholders for different purposes in the project, and we have established what we call a citizens and patients advisory group, which basically have two focuses. One is focused then on to support the overall project when it comes to advices on the citizen perspective. And the other purpose is to be available as representatives for the citizens that are stakeholders in the 4 regional testbeds. Next, please. When it comes to governance, we all understand that being a stakeholder means that you have a home organization where you have your respective systems and governance structures, etc., to take into account, and still you should move into this collaborative setup. Next, please. Here we also have, say, learnings and knowledge from research, and in these types of setups, there are different structures on how governance could be implemented. It could also be like that there are different structures for governance for different set of decisions, etc. So we could identify 3 different governance structures, as well as a set of different governance principles that we always have to be a bit careful to consider when we are defining each specific intervention or test that we are going to run. Finally, then, an illustration of, next please. Finally, then, an illustration of another perspective of this is that if we claim that we are going to collaborate, then we have to have enablers for this. So we have to set up and define what type of structures do we have that could support us in collaborating, and what type of data do we need in order to have transparency, etc. In quite a few cases, this is a multi-layered setup, where there are, say, issues in relation to the implementation of the portfolio of interventions within, say, a municipality or a local setup. And then we also need, at the strategic level, we need coordination and strategy and how to finance and spread best practice, etc. And we end up with a multi-layered structure with different types of needs, both for decisions as well as for co-creation at these different levels. Thank you. And then I hand over back to you, Alison.
That is wonderful. Thank you so much. And I am sorry to rush you along because, of course, 18 to 20 months of work is very hard to summarize in just 45 minutes. So I think you've done a wonderful job between all of you. Thank you, Joanna and Jacob, Balázs, Bengt, for all of your excellent contributions. And what I neglected to say at the start that I think is very important to emphasize is that our hope is that this is a first discussion with at least some of you who are involved with us here today. We hope that this is going to be an ongoing collaboration, and we would love to have more in-depth discussions with you about each aspect of the research outputs that were presented so far. We did eat through our question time, but I did see people making good use of the chat. So if you have questions you'd like to submit, please send them there. If you have something burning and you can't use the chat, you can raise your hand and we will make sure we get to you. But otherwise, what I'd like to do is already directly invite our panel to take the virtual stage here. During the panel, as I said before, we're going to be hearing from 3 different experts who have distinctive perspectives. And we think that looking at those perspectives together, we're going to be able to get an interesting answer, or let's say an interesting series of answers to the question, why do we need innovative financing of health promotion? So what I'd like to already do is start. We'll go with each panelist one by one. We'll be starting with Caroline Kostongs, followed by Gonzalo Andrade, followed by Lars Munter. Each will have about 5 minutes to give us, let's say, an opening argument, and then we're going to open the floor to everyone, whether that be a colleague of the project, whether you're joining us for the first time. We really hope to make this interactive and to get your thoughts and feedback on what we're presenting. So now, without further ado, I would like to welcome Caroline Kostongs, who is our director at EuroHealthNet, and she has been a prominent advocate for increasing investment in health promotion. She was a driving force behind EuroHealthNet's e-guide on financing health promotion, which I will speak about a bit later on, and was also active in the steering board for social investment in Brussels, which was a grouping of different social actors in Brussels trying to really build on some of these recommendations from the report that Joe mentioned at the beginning about increasing investment. So Caroline, thank you for being with us this morning. And I'd like to start by asking you, how can putting more emphasis on health promotion help us to make our health systems more sustainable? And how can we build the confidence? I think this is very important. How do we build the confidence of health professionals to advocate for more resources for health promotion and disease prevention? So thank you, Caroline.
Thanks a lot, Alison. It's very nice to listen to all the presentations until now in our project. And I think it's very timely that we meet today, because actually today and tomorrow, the finance ministers of the EU countries are meeting in Brussels, discussing the European semester, which is a broad European Union economic tool, but also discussing whether countries are staying within the public budgets, and also discussing what to do with the countries that have excessive deficits. So, and we are quite concerned, because some of the measures that we are hearing in some countries also, it's almost sounds that it's sort of leading to more austerity measures, which is obviously not good. I mean, if we look at some of the countries, Sweden, Finland, the Netherlands also, they are cutting quite some budgets for the mental health institutes, the public health institute, and a lot of the work on prevention is going to be reduced, unfortunately. And also at the EU level, we see that there is a cut in the budget of the Invest4Health program of 20%, which is quite worrying as well. So today, actually, we at EuroHealthNet, we are launching a report. We disseminated a news release, which I hope you have received, in which we are saying that when the finance ministers meet to discuss the economy, that they should definitely look into how we can make it a well-being economy, so that investing in well-being of the people and well-being for the planet, what are the return of those investments and how that actually contributes to the economy. And we are also asking the Commission to look beyond the GDP indicators and indeed see what is the genuine progress that we are making in our societies, and what better indicators we should use to demonstrate impact on health and well-being. And also we asked the Commission and the finance ministers to revisit the return on investment tools, to make sure that they see that it is indeed an investment if you invest in health, and not a cost. I think we all know the famous figure of investing €1 in prevention that gives a return of 14 euros. And this is basically mostly due to investment in false prevention of frail people. But there are other figures out there, for example, investing in early childhood education. €1 invested in early childhood education leads to €3.50 in return, which with also additional benefits of women entering the labor force. I find data on €1 invested in thermal renovations, so making sure your houses are warm and have adequate heating. That brings a return on 42 cents, but still in healthcare savings by reducing the health risks due to dampness in houses and so on. So the case can be made. The case need to be made in economic governance, like what the finance ministers do now, but also practically for interesting investors to invest in the kind of policy measures and interventions that we would like to have, very much related to Balázs' work on the value propositions to investors. So we need to be more confident, using the word that you were saying, Alison, confident in making those value propositions and with justifying what the expected return on investment is that we expect to have. And we also need to build confidence and capacities to generally navigate the world of finance. No, I mean, in the project, what we did spend quite some time is to understand each other language, because in our project we had economists, we have investors, public health people, and it takes time to understand the language and the words and the concepts being used by investors and by economists. And we need to do that better and to understand what are impacted social impact bonds and how to use banks. And also we need to talk to investment banks out there and to make them understand that you shouldn't always need to build hospitals and high-tech centers, but also invest in community-based primary care and health promotion, disease preventions, and then offer indeed the data how that best can be done. And I think that is most important, and therefore the Invest4Health project is so timely now also to give us the capacities and the confidence to enter these debates. And also the e-guide that EuroHealthNet is updating will also be helpful there, because there is a lot of competitiveness out there for public budgets. There is the wars, defense budgets, climate, very important. And we have to make our case in health, in particular health promotion and disease prevention. And therefore, I'm happy to see so many here. And it's great to see if we can get more regions on board to work with us on those smart capacitating investment models that we have been presenting here today. Thank you, Alison.
Thank you, Caroline, and a lot of food for thought, many different opportunities, hooks. Yeah, so much happening now, and I agree. It's really a critical time where we're coming to a bit of a sugar crash, no? After we've had so much funding coming through COVID-19, and now indeed what comes next. And there are a lot of competing priorities. So it's very important for us to be able to make those arguments to the public sector, as you said. But now I'm happy to have a representative joining us from the private sector. I'd like to turn to our colleague Gonzalo Andrade, who's a partner at Indico Biofund within the Indico Ventures partner SGR. So hello, Gonzalo. Indico Biofund invests in development of innovative pharmacological therapies, but Gonzalo has kindly agreed to join us for this discussion on something that's quite different, this in health promotion topic, which might feel sometimes like landing on a foreign planet. So I'd be really keen, Gonzalo, thanks again for being with us today. I'd love to know from your experience investing in pharmacological therapies, what could you tell us about how we could make our work in health promotion, trying to invest in health promotion, more attractive to investors, understanding that we usually need to work with much longer timeframes and it's much more complex to measure our effectiveness. So any thoughts you have are very appreciated.
Thank you very much, Alison. It's a pleasure to be here, and thanks, Joanna, for inviting me to participate today. So, as you indicate, I represent a therapeutics-only fund, so 100 million in size, and this would be classified as a tertiary prevention in that sense, in the prevention pyramid that was presented earlier. I have 9 years of experience in managing other people's money as part of investment funds. I have the luxury of being a part of a firm that has over 500 million in assets under management today. And my first fund was an evergreen fund of 20 million euro that did diagnostics and medtech medical devices. And as a result, it would be more related to the secondary prevention range within the pyramid. So I can primary prevention. I've not. I don't have that much experience in investing, but in terms of secondary and tertiary prevention, I think my career in the investment space has been all along those lines, and it's a very different beast in the sense that most of the funds that so first you need to consider that most of the money that we manage for third parties, we need to pay it back, and typically there is a typical time frame for giving it back, and as a result, the outcomes and the financial return for the investors that give us money to manage on their behalf need to be there, and the ability to get a second and a third fund and a fourth fund is linked to the return that you generate for the investors, and they're expecting a return more than inflation rate and more than the stock market. Otherwise, they would do it themselves and invest in bonds and also in the stock market themselves. And as a result, our work is measured against the success and the returns that we generate. And so, in the case of types of funds that I've managed, I basically have the luxury of having a fund that is 10-year term today. But in the past, I ran an evergreen, and an evergreen is a fund that does not need to be paid back. So it's basically a self-propelling entity like a foundation, and then you can recycle the investment and the proceeds of each investment, and basically you get a self-sustainable ecosystem. So those are typically those. Like I'm familiar with those types of investments and investment vehicles, and happy to discuss further how this would be applicable to the current discussion. And in terms of bonds, I've seen a few social impact bonds. However, in the concept of reporting to the investment funds, so in the context of reporting to the local banks and to the local depository entities, it presents a problem in how to value it, and it becomes a difficult discussion to value it in a fund that needs to be paid within 10 years. So that's. I can start. I'm happy to discuss and listen also further from you, Alison, if you want to have additional questions or have additional items to cover. I'll be happy to.
Thank you so much, Gonzalo. Yes, I think it'll be great to have your perspective indeed, and I hope we will have some comments coming in from participants, and we'll be able to hear a bit more what their experiences have been. I think you've already given I'd be curious where the evergreen fits into the flowchart that we've discussed earlier, and just kind of these details of valuation. Is there a way around that question of how we value things so that it would be more attractive to work with something like a social impact bond? But I hope we'll have time to get to that in a bit more detail in a discussion. For now, I thank you again, and I'd like to pass to our final panelist in this lightning panel we have here, and that is last but certainly never least, our colleague Lars Munter, who is the founder and international director of the Nordic Wellbeing Academy, and also a member of Invest4Health's Citizen and Patient Advisory Group, which you saw on one of the slides that I banked through. So Lars, it is really a pleasure to have you with us here today. Thanks so much. I hope the connection is all right, because your camera's a bit pixelated. You hear me fine? Okay.
I do.
Great.
Sure.
Perfect. Well, your camera's coming in and out of focus, but we hear you. I wanted to ask a bit, coming from that citizen perspective, what Caroline was talking about, I think is really, advocacy work we're doing at the level of Brussels is quite top down. You know, we're really looking at those policy and decision makers, those finance ministers sitting in Brussels together. But how can we bring citizens and patients along? What is that role? What is our responsibility toward getting them involved? And I think, how do we close that loop? There's an essential element here of working with citizens and patients for the sake of working with them, because we need to have a social participation and we need to have a participatory and genuinely participatory approach. But also, how do we leverage that so that those citizens and patients help us generate more political will through their voice, through their advocacy, so that we're not only going to the policymakers by ourselves, but they're also helping us reach them from the other direction? How do we do this more effectively?
Well, and thank you so much for asking me to join. A proud member of EuroHealthNet as well, just for the sake of transparency too. Joanne earlier mentioned that she'd been told by someone that using metaphors would be a good idea, and I might actually be the responsible guy for that particular comment. The role of metaphors is not the key element here, but the role, of course, of the underlying stories we tell, the way that we are able to share the true value of the smart investment models. Can we explain these models to the citizen, to the voter, to the adolescents that are going to use this? If we can share the story of why, then of course it becomes an easier choice to do. So there's a role of involving the citizens and the patients in requiring of ourselves to be able to share the story of why we're doing this. If it's a too complex story, it doesn't really go well with the policy stakeholders that we're trying to get to use this, and it doesn't really go well with their constituencies in the end. Trying to explain a, well, nuclear bomb is tricky. And of course, you just need to say boom, and maybe that's it, all you need. But joke aside, in essence, it's of course absurd that we have to argue about the value of investing in a good society. But there's a reason why we have to argue about that. And one of those problems is of course that the underlying problem of our current economic system is that it's destructive by nature. In the wonderful pyramid of prevention that we had before, we tend to forget that there's a reason why things need to be prevented. The current trajectory, and we're not necessarily thinking about super tankers now, but the current trajectory of a lot of different elements, outcomes of economy, is destruction. Either destruction to the planet, destruction to human health, destruction, and so on. So we talk about preventing something that we sort of know has a reasonable likelihood of happening unless we do stuff. And when we're talking about the well-being economy, is because we want actually to have less likelihood of something bad happening. And getting that done is then trying to do something that hasn't really been done before. It requires quite a bit of trust to make the mechanics of the well-being economy work. It requires quite a bit of trust to make these new financial models work. So the key role of involving citizens in that is that you have the ability to talk about what generates trust, what generates enthusiasm for taking that step into the unknown. When we're talking with key stakeholders, a good question is this something that our European citizens like, understand? Are they enthusiastic about it? And demonstrating that as a key also stakeholder on our side is really important. With a half joke, or maybe with a little bit of cynicism, there are so many things that we can see that are invested in with no return of investment whatsoever at this point. So having to argue that we as public health is a good investment is an absurdity in itself. And unless we also show that there are others that can see that absurdity, aside from the public health professionals, it becomes a much trickier proposition. So it's really good work by Bengt and his team to show and understand the complexity of the stakeholder landscape, that we need even more. We need to involve them because the complex wicked problems that we have will not be solved by simple solutions. So this points to elements where we need much more mission-driven partnerships with the citizens and patients as one of them. We need solutions that they can understand and appreciate and be enthusiastic about in their daily lives. Not necessarily about the, if you will, social impact bonds I like. Regular bonds, who cares? Technically, I mean, there's a few investors who like them, but most people don't really care about bonds or financial tools. They care about their daily lives. They care about what the bonds deliver, obviously. So explaining how these social impact bonds will be the key to your new playground. They will be the key to your new social housing, or the case that Caroline mentioned before. We're talking about social impact bonds because we want to make sure that you have a good and heated house next winter, and so on, in a way that doesn't destroy the local stream or the local ocean, maybe. So that is the role of trying to get them, because when we involve citizens and patients, we need to be better at explaining what we do, and we also gain another another army on our side. And pardon that analogy and metaphor, because it's not a nice one, but one that we need nonetheless. So that's a key element to rush through that. Yeah.
Thank you so much, Lars. And indeed, maybe on our team, we do live in a very competitive space now with a lot of different competing priorities, as we said. But I really take away that we need to make things simple, not just for citizens to understand, but indeed for policymakers. This is essential for our advocacy, that it cannot be too complex for anyone, you know. And I think just getting the conversation right between ourselves has been a challenge in the last 18 months, as Caroline said. So there's still a lot more work for us to do there, but I'm happy we have the remaining 18 months to continue to work with you on the CPAG, for example, and across our consortium to sharpen these messages, simplify these messages, and really try to gain more trust. As you said, I think trust and simplifying messages are the essentials I've taken from that. Thank you so much. I see a few, it is 11:15, which is when I promised you your well-deserved break, but I do see a few comments in the chat for Gonzalo. I don't know if you're able to see those, Gonzalo, that there were some questions for you around your investment approach, or around investment in prevention more broadly.
So I can try to see the comments. Let me see. Okay. So could you please share some examples of investment in prevention generating close to or exceeding stock market returns? That is really very exciting, right? Okay. So in primary prevention, it's difficult to monitor and to measure that. However, in the sense that most of the money available from help limited partners into the funds are channeled through to therapeutics or to secondary or tertiary prevention, not to primary prevention. Nevertheless, the best performing funds invested by the European Investment Fund over the past 15 years have been in tertiary prevention, and they have generated over 30% per year for the people that have invested into those funds. Much better than IT and digital interventions and systems, right? So that is historically over the past 15 years, the best performing funds of the European Investment Fund have been in the tertiary prevention space. So there are a number of examples like that that generate over a 10-year period more than 30% year-on-year returns. So if you do the math, it's basically you get 8 times your money after the 10 years. That's sizable. Okay, and then the other question from Graham was, you sometimes co-invest into non-commercial entities to enable investment in projects that might have longer term or lower returns. Right. So this is a good question, and I think this is the crux of the discussion, because in the fund that I presently manage, we are already at year 3, and we have 7 years left in the fund to stop investing and do exits from the projects that we've invested in, and return the money to the investors that have given us money. And the investors that have given us money are foundations, banks, pension funds, and the like. So they are doing their best to manage the retirement plans of the people that give them money every month from their salaries, right? So that's the overall people that give investors like me their money. So to that effect, in the current fund that I manage, it is unlikely that we are going to invest into a project that is not going to be able to exit and return the money before the 7 years that are left in the fund. So that is one of the key elements. On the other hand, if I had an evergreen fund like my previous fund before, the evergreen funds can invest into a long period and a lower return, but it will need to balance the portfolio with other more risky and potentially more higher return investments in order to compose the portfolio in a proper manner. So that's something that we typically do, and I did in the evergreen fund that I managed. And this is also the same thing if you consider corporate social responsibility or corporate funds, and they would consider a long only approach. So a long only meaning a fund that so an investment that you can wait until that you can wait longer than necessary longer than average to get your return on investment and get your money back. But it's possible. So there are a few investors that are long only, and these are typically foundations, pension funds that are also able to do invest in these types of projects. It's difficult for a fund that has a defined lifetime to be able to accept an investment into a longer term, lower return, given that the fund manager, like me, will only get paid a bonus when it beats the stock market. So in order for me to be the incentive that the fund manager has to outperform the stock market is linked to his paycheck. So given that that's the incentive that we have, we are typically more inclined to accept projects that generate higher returns than projects that are generating lower returns. Okay, so does that clarify your question, Graham?
I'll give Graham a minute to see if he wants to add anything else, or if there's anyone else. We are a bit over the time, so I do want to wrap up the discussion here in a moment or two. Is there anyone else who would like to add? Yes, Lars, I think you want to respond. So.
Yes, please. But it's a very good case in point. One of them that the key incentive mechanism for these fund managers is one of the elements that creates the tendency to go to these high return types of investments, or at least drives the need to find them. However, though, there are both investors out there that do not have that type of incentive scheme for their fund managers, but they can also not invest unless the different investment options are able to speak the language of money. In very basic terms, of course, when you are an investor, you need to know more or less how much money you're going to spend, reasonably how soon you're going to get your money back, and what the risk involved would be. From a legal perspective, that's sort of what you need to know as a fund manager. And so when you ask someone, if someone approaches a fund manager and says, I would like some money, I don't know when you'll get them back, but it's for a really good cause. I mean, that is not speaking the language of money. So we need to be better in the public health arena to also be able to speak the language of money, to be able to say with confidence that we need X amount specifically, we're going to get them back within 5 years, 10 years, whatever. We believe that the outcome will be 2.6% because that has been proven in previous blah blah. The cases that were presented earlier today about the social impact bonds, powerful cases. Let's use them and of course replicate them in other cases, because they show that you can speak the language of money for the public good.
Yep, I agree. I agree, Lars, and I think I would add to that that multi-million funds like the one I manage are unlikely to deploy their investment capital into 400,000 euro opportunities like the one of Project Familia, for instance, right? And that because simply it takes as much effort to do a 400,000 euro investment than it does to do a 5 million investment, and as a result, the types of investments and the size of the funds that are available are also important to understand, because if you're talking to a 100 million fund and you're asking for 500,000, it's not going to be the right partner to talk to, right? So that's the very important aspect to keep in mind. And in terms of policymakers, the fact is that most of the fund of funds are across Europe. So basically, fund of funds are money from the government that is available for investing into funds like the one I manage. And in those fund of fund rules, they clearly articulate the types of projects or the mandate that is supposed to be followed, and what is the expected return. And so the policymaker that actually set up the fund of funds and the rules for the fund of funds is already defining that the social impact investment and the investments that generate lower than 10-15% on a per year basis over a 10-year period will not be eligible for financing. So that, in terms of if the reasoning behind this is to influence policymakers, then I think the one item that I would flag is that policymakers should consider that in order to have these kinds of investor pools, then the rules for the fund of funds need to be adapted to do social impact bonds and also other types of initiatives. Otherwise, you cannot compete with IT investments or to pharmaceutical therapeutics investments, because simply the returns will not be there.
Right. I'm so sorry. I think what would be great is if we could, as I said, this being a first discussion, if we can take this and have really a crack at understanding how to speak the language of money better, and understanding what are the realities better, then I would love to have a follow-up on this. For now, I am going to pass, maybe Caroline can give us the closing word on the panel, and then we will break for our break, and I would suggest we come back at 11:40. So if Caroline, you could see us out of the panel, and thank you so much for the fantastic contributions.
Yes, thanks a lot so much for Lars and Gonzalo also to share your insights. Very useful. And indeed, I agree that one of the difficulties we have in health promotion and disease prevention that our projects are too small. We need really to scale up to really make a very interesting value proposition in investments that we do need. I do think that there are investors out there that want to make impact and social impact or sustainable impact. And I think that we can learn much more from the green field, because I think in the green and the environmentally sustainable investments, I think we can, they are ahead to us in social impacts and health impacts. And I think that we can do much more learning from that area as well. And yes, so I think it was very, very interesting, all a very important debate, and we need more time to debate this. But we will have some time after our break as well. So I look forward to see you all. I don't know, what time do you want? Are you giving us,
I suggest 11:40. It was going to be 11:30. It will now be 11:40, which challenges those of us of the second half to be efficient, but we'll do our best. So let's see you back at 11:40, everyone. Thank you so much. Thank you. Okay, we're now at 11:40. If people could just put their cameras on if you are there, so I have an idea of just how empty the virtual room is still. Seeing some people come back. Welcome back. I hope you were able to use the break. So great, good. Okay, wonderful. Well, sorry we're a bit behind schedule, everybody. I will do my best in the next section to practice what I'm preaching and keep myself to time. But thanks, and hope you had a nice break and you've enjoyed the first part. Now we are in the second half of the agenda, and it will be my honor and my pleasure to present to you the first part of the next session, which is all around how Invest4Health can help you. So I'm actually going to launch the slides myself, David, if I find them in the right place. Here they should be. All right, and do let me know if you can see that, because now I've lost all of you on my screen. Is that okay, David?
Yes, I see it.
Okay, great. Well, then I will go ahead and kick off and start walking us through how Invest4Health can help you, and specifically how Invest4Health can help you to apply innovative financing models in your own context. There's been a lot of activity. You heard about our research outputs. There's also been quite a lot of activity already ongoing throughout the project to understand what it is that our pilot sites, in this case, needed, how we could support them with the work. So there have been many different activities, and what I've tried to do is condense them down into a series of steps. And so I'll walk you through the steps of what types of things we can do to support you, and then I'm going to be passing the floor to my colleague Theo, who will be telling you more about the open call that we're going to be launching already by the end of this week. So step one in this process of us potentially supporting you, assessing readiness and maturity in your context. So, and by this we mean the maturity to increase the resources available for health promotion. How do we do this? Well, one of the tools that we have at our disposal, something that we have been using so far in the project, is an adapted version of the Scirocco maturity model and self-assessment tool. And you may be familiar with this. You may have seen it from other projects. I believe it was first designed in 2015. Our colleague Leo, who I think is on the call, can correct me if I'm wrong. But it's been adapted since then for many different projects, and we've used it in this case for Invest4Health to look at readiness to apply smart capacitating investment models in different contexts. The objective of Scirocco is to help capture the perceptions, forgive me, of diverse stakeholders around maturity and readiness of their health and care systems. And this is done around the 12 dimensions. You see a sort of rainbow around that family on the left. These are the 12 different dimensions of the health and care system that are evaluated. Using the Shiroko tool, you can facilitate multidisciplinary discussions and dialogues that help you both identify strengths and weaknesses of your current system and build consensus about the current situation to inform future actions. So normally you would first evaluate the system individually as an individual stakeholder in the system, and then everyone brings their collective scores and you discuss them together to try to come to a consensus number. It's graded on a scale between 1 to 5, and I'll show that on the next slide. And what this then serves to do is provide a basis for further improvement. You can look at the particular dimensions and see what type of training or what type of coaching or what type of other support could we take advantage of to help us improve our score in this particular dimension. So these are the scores of 3 of the 4 test beds that they self-scored. There's self-evaluations of their current maturity to adapt and adopt SCI models in their context. And so you can see that they had very different perceptions and very different areas where they felt that they had strengths and weaknesses. And that helps give us an indication, this assessment of where we could go from here. And more broadly, I think it's important to think about the fact that organizational readiness is not something that happens like a flip of the switch. It is really an evolving process and something that we create over time. So engaging with a project like Invest4Health can offer a sort of clarifying focus or an excuse, if you will, to have these conversations, to frame questions, identify relevant actors, think about how the work relates to existing initiatives and activities. So you may have a regional action plan that you're struggling to think, how can all these different components of the plan be achieved? Maybe looking toward multi-annual budget planning. How could these tools, this idea of assessing your current maturity, how could that help you? And within the consortium, we do have partners who could be, let's say, informed and neutral third parties who could help you to catalyze and facilitate these sorts of discussions in your context. Step 2 is all about support to define a common vision for the future. So before we get to the future, though, we do look at the present. And similar to the last slide that I showed, a lot of work that has been done by colleagues at the Research Institutes of Sweden, RISE, around logic models and problem trees. So trying to get to the root of the issue, forgive my pun. Invest4Health can help you walk through different logic model processes, identifying the value proposition of your proposed intervention and a potential investment case. There was also a lot of work done. This is an example from early days in Skåne region, looking at the challenge of a lack of coordination around early childhood interventions. What are some of the causes of that, and what are some of the consequences? So really understanding the context again, where we are, and trying to align our vision. The other thing that we've done has been looking toward the future. We developed a foresight methodology within the project, which helped our pilot sites to answer the question you see here. How can we increase sustained investment in health promotion and disease prevention from within the health system and beyond by 2040? And we condensed, I would say, at least 6 to 9 months of work into a couple of graphics here. The first that you see on the left, the horizon scanning, this was conducted by EuroHealthNet along with other partners in the project. We took relevant trends from future-oriented reports and resources and pulled those little trends out of the report. We then plotted those trends. You see a sort of rainbow at the bottom. And of course, I know you can't read that text. It's just to give you an idea. But we plotted that then using the PESTLE diagram, P-E-S-T-L-E, political, economic, social, technological, legal, and environmental trends. And we determined whether we felt they were short, mid, or long-term trends. And during a workshop with participants from the Invest4Health project and stakeholders from our 4 pilot sites, we validated these trends. Are these, in fact, the trends that have the most relevance for us? Have we looked at them correctly? Once we validated those trends, we did the final step you see here, this cone of plausibility on the right side of the screen. We looked at generating future scenarios. And so taking the trends that we agreed were relevant, what would happen? What is the probable future scenario by 2040 if these trends continue on the same trajectory they're on now? And what would be the preferred future scenario if we were able to influence on these trends? What could that future scenario look like? And so there was group work done across all of the pilot sites across the project, But then that work was also taken down to the level of each one of our testbed locations. We had in-person meetings. Well, one ended up being online, but it still worked. It was a nice small group together. But we had 4 meetings locally, and we really dove into the specifics of the context where our partners are working, both the geographic context, the context of their health system, but also the interventions that they want to achieve, that they want to put into place. And so this is just to show, again, I know you can't read these post-its, but we did backcasting exercises on the basis of our preferred future scenarios, and using the backcasting results from Scirocco, putting everything together, we were able to come up with some action plans for each region to then identify concrete steps they could take toward achieving their goals by 2040. So that was our work around common vision. Step 3 would be around addressing the needs for training and advocacy. This work has been led by our colleagues at IESE Business School in Barcelona, and it's meant to help address the needs that we can find through this assessment work that we've done, understanding where we are today and where we want to go, what are our gaps, what do we need to do. So this Invest4Health training program for policy and decision makers has the primary objective of enabling participants to understand, evaluate, and apply SCI models within their region and or at organizational level. It also is meant to foster sustainable solutions using evidence-based decision making and strategic investment. Target participants would be decision and policymakers from various organizations that are involved in achieving health outcomes. So this, of course, would be health authorities, but not only health authorities. It could also include patient associations, foundations, and other public sectors such as transport, housing, education. It really depends on what you want to achieve. And what is the format of this? Well, it's currently 11 modules delivered through online workshops in a learn by doing format. And it incorporates real world case studies like the ones that we saw from Jacob earlier. And it's currently under development and being continuously iterated with our existing pilot sites. So now I will do a very quick whistle-stop tour of the 5 learning objectives and the modules that animate this training program, that are part of the training program, so you can get a sense of what it's about. So training modules 1 through 3, what is smart capacitating investment and is it right for my context? So here's some of the elements of what you would learn would include what is SCI, which I hope you have a better sense already. What are some examples? So we dig a little bit more into the examples. What are some of the critical pain points around the problem that we need to solve? What is supporting data I have available? What makes a good team for me to try to address the problem that I've identified? Training modules 4 through 6, this is all about definitions. How do I define my problem? How do I define my target population? And how do I define and measure my outcomes? So here around defining the problem, I always think of the expression, a problem well stated is a problem half solved. So really getting into the details of how do we understand this problem and what do we think that the solution could be? Who is our target population, and being as explicit as we can be, understanding that that's going to help us more clearly measure how effective we've been at reaching them and reaching our aims toward improving their health, and then defining our outcomes. So looking at hard and soft outcomes, outputs versus outcomes versus impact. So digging into all these details. Training modules 7 through 8 are asking who are my stakeholders and how do I incentivize them? And I think this comes back to what Gonzalo was saying before as well. It's all about incentives. You know, what is the incentive for someone to want to work on this with me, and really aligning those incentives as well as we can. So that's really the driving force behind modules 7 and 8. And then that takes us to modules 9 through 11. How do I make this sustainable? So what is your business model? What is your finance model? Do you have the potential to scale? These are the kinds of questions that we would be exploring in these 3 modules, these 3 final modules of the training program. And so that's just to give you a sense of how this looks. If it's interesting to you, well, here are the prerequisites. In a single phrase, skin in the game. Please, you need to have skin in the game if you're interested to work with us on this. You should have a significant stake in the outcome, and the commitment should go beyond just signing up for the training program. That would imply either financial or non-financial investment, and some examples include gaining or maintaining political buy-in, maybe engaging external organizations who also have a stake in the problem, dedicating additional resources to it. So you can see what might suit you, but this is an important prerequisite for getting engaged in this work. And I would say in the open call that Theo is going to be presenting to us in just a couple of minutes. The last thing I want to say here before I go on to step 4 is all about advocacy approaches. We had the chance to speak a little bit about this before, and here's a QR code to the not yet updated e-guide for financing health promoting services. But as mentioned, we are working on taking the examples that have come out of the Invest4Health project until now, the excellent case studies we've found, the messaging, our better understanding of really what are the challenges on the ground, and we will be updating and relaunching the guide in early 2025. And just to explain again why we think this is important, the training program, of course, helps you build the technical capacity that you need to implement the work, but really having solid arguments for advocacy, arguments that are in simple enough language for everyone to understand and appreciate and get behind. That's going to give you the confidence. You might have the technical skill, but maybe not the confidence. So this is where we hope that we can work hand in hand with that training and over the course of the next 18 months as the implementation of the project really moves forward, that we can continue to develop these messages. So stay tuned on that front. Finally, step 4, it wouldn't be a research project without having some component of evaluation, right? So I have taken the liberty of changing a bit some slides, so I hope our colleague Apo, who is here on the call, will forgive me. I simplified a bit. Our University of Oxford colleagues have been leading the work around this, around
1 minute
evaluating.
left, Alison.
Thank you. Perfect.
Yes.
Thank you. So around evaluating complex interventions, and I'm just showing here the Medical Research Council framework that they've been using from the UK. And what I think is interesting to mention about this framework is that it challenges the view that unbiased estimates of effectiveness are the cardinal goal of evaluation. And it's much more about understanding how interventions contribute to change, the dynamic between the intervention and its context, and helping us have a better sense of our theory of change. And is our theory of change accurate? Is it not? And so this is just to explain a little bit more about the step-by-step process of the evaluation work. I won't go into those details, but this is just one more area where we would be able to provide support to you if you would be interested in coming along on this Invest4Health journey. So having said all of that, I'd now like to pass the floor to my colleague Theo, who's going to be speaking to us a bit more about the open call.
Thank you, Alison, and thank you for presenting the great work that has been done so far in the project. Also, many thanks to the other speakers. So can I prompt when we can go to the next slide? Great.
That's perfect.
So next slide, please. Great. So you've heard all about how we have developed the SCI concept and where we've ended up so far. You've heard about the different activities we've been doing in our test beds, and also the different inputs that we've gotten and the refinements that they helped us do in our tools. So now it's time for us to open a new call and invite new stakeholders to join us and essentially help us get feedback on what we have developed so far, but also help you, potential applicants, to also build your competence on the things that we talked about today. So eventually we will also, let's say we want to work together on this so that we can kind of develop our concepts and validate our concepts further with a vision to scaling and kind of replicating this in different places, and of course, which will help us scale our results and eventually our impact. So if you would go to the next slide, please. So what is the open call about? So to boil it down to the very basics. So we aim to support new regional test beds by offering capacity building activities and simulation exercises in this phase. So you've heard, Alison, you talked a lot about earlier about the different training programs you've developed and the different modules that you are, let's say, able to learn more about. So essentially, we would like to build these activities and work with you on testing these business models that you've saw today and heard about, the financial and investments model on health promotion and disease prevention initiatives. And essentially, the activities will be developed by and delivered by the Invest4Health consortium partners. We do not offer any financial compensation for participation. So the open call is about you having, your skin in the game, as Alison called it earlier, and wanting to learn more about this, and also learning what are the steps you need to take to put it in practice and kind of leverage new innovative financial and investment models in your initiatives. So, and of course, we will, through your participation, we will learn more. We will refine these models. We will refine our modules and our trainings, and of course, will help us generate impact on a local, national, and European and international level, of course. Next slide, please. So to summarize this a little bit, or try to put it into a context. So here you see different stages that we've talked about earlier today, from understanding needs to essentially conceptualizing solutions and refining and testing. So the different activities we will offer under this open call will cover a multitude of these segments, let's say, depending on how developed your initiative is. So we will help you understand your readiness and your needs for testing and implementing such novel financial and investment models. We will help you build your capacity and your competence on these ways of financing. Of course, we will help you and participate in simulation exercises of how SCI could be adopted in your region and solve your challenges, of course. And of course, we will give you the opportunity to connect with other testbeds who will participate, and of course, with our current testbeds in the project, so that you can learn from each other and collaborate also potentially in the future. Again, I can say here that it's not necessary that you go through the whole program, but then there will be a kickoff meeting. I will explain that in the next slide as well, where you will meet the Invest4Health partners, and then you can decide based on your, let's say, needs. You will decide which parts of this are the most useful for you. So next slide, please. Who is this call for? So if you're a local or regional government, a city or municipality representative, health authorities, community-driven initiatives, social enterprises who are trying to work on health promotion and disease prevention, or any other actors in this field who are working on your initiatives right now, and you are interested in exploring new innovative ways of financing, and of course, you have a problem to solve or a skin in the game. I really like that, Alison, so I repeated that now again. So this call is for you. So we would be very happy to hear from you, and of course, see you apply for it. Next slide, please. So more practical information. It will be available in our website by the end of this week. So please put a reminder, but I'm sure that we will also remind you, to the participants of this call. We will remind you and we will let you know when the documents are available. They will be available by this week, by Friday, essentially, by the end of this week. And then the application deadline will be on February 27th. So the call is open for around 2.5 months. So you have plenty of time to read the documents. So there will be an open call document which describes in detail what I have explained now in summary. And then what you can expect is that we will respond to you by mid-March and let you know about the outcome of your application. And then activities will kick off in May 2025 and will run through until pretty much the final stages of our project in Q2 2026. So again, I will refer you to our website, and then we will follow up with more information on this. And any questions, of course, you can ask us. We will have a dedicated email address where we can respond to any questions you might have. And there will also be an FAQ document on our website that you can find some answers to the questions that you might have. I think I will wrap it up here and then open the floor to any questions as well. So thank you.
Thank you so much, Theo. So I'm going to go ahead. I think we know what Q&A looks like. So I'm going to go ahead and stop sharing the screen. And if there are, I mean, we're tight on time as we always are, but if there are questions, then we would be very happy. I think I see from Mariana some questions in the chat. Maybe you would like to take those, Theo.
Of course. Let me open the chat.
Yeah.
Yes. So is that question, the training program, is that question to, I think that question was for you, Alison, the first one.
When it was,
and the second one is for me.
Yeah. Okay. So the training program is more or less already running in a very iterative fashion. So it's one of these things where right now it's still happening it's not something that is yet online, for example, and you can access it and start going through it at your own pace. It would be something where we would be able to connect you with our colleagues at ESA Business School, and then they would be able to give you more insight into how they could support you with the modules. So some of it is already available, but I would say it's not yet in such a final format that we can send you a link to it and you can start using it, if that helps answer the question. Maybe you want to take the other one, Theo.
Yeah. Could the European projects potentially be candidates for the open call application? I mean, if you're representing or working on an EU project that is relevant, then or other European projects, then of course you're welcome to apply. This is, as I said, it's a call for us to, because we have the different content we would like to help you build your capacity with. But of course, you know, it's up to you. If you're interested and you're representing your organization or your project, then we're happy to hear from you and happy to collaborate. It's a call for collaboration. You can say it as such. So thanks for your question.
Thank you. Are there any final questions before we go to part 4, our final section, where we'll hear from our current testbeds? I don't see more questions in the chat, and I don't see any hands raised. So maybe if David could go ahead and launch our final slide deck here, then we will hear some practical examples of what our testbeds have been doing to date. So each one of them has prepared a set of slides for you. We'll be going in order that we randomly assign. So we'll start with our colleagues in Galicia, we'll move to our colleagues in Wales, then we'll go to North Rhine-Westphalia, and as we started the day with Skåne, we'll close the day with Skåne as well. Each one has been asked to answer 3 questions. So tell us about what intervention or what you're trying to achieve in your context. How has being a part of Invest4Health benefited you to date, and what are your next steps? So having said this, could I pass the floor now to Beatriz, who's our representative joining us today from Galicia in Spain.
Hi everyone, I'm Beatriz and I'm going to talk about the Galician testbed. Could you please go to the next slide? To the next one. Okay, so Galicia is in the northwest of Spain. We have 2.7 million inhabitants and the government is autonomous. In the health area, there's a low geographic concentration with many sparsely populated rural areas, which is a problem for us. About the health system, Galicia is divided in 7 health areas covering specialized and primary care. And as I said, the low geographic concentration, there are difficulties for isolated populations in accessing healthcare. We selected a project about cystic fibrosis, so I'll give some data about this disease. It's a disease that affects the whole population, both pediatrics and adults. There we are collaborating with the Galician Cystic Fibrosis Association. There are 83 patients in that association, but the estimated number of patients in the whole region is around 120. And to provide an example about the population dispersion, for example, in the province of A Coruña, there are 41 patients, but only 12 live in the city. So it's really difficult to access healthcare. Next, please. So we selected as the pilot project this cystic fibrosis disease. These patients need continuous monitoring of their disease by different types of professionals, both primary care and specialized. We selected this project because we received a proposal prepared by this association that aims to add to Telea, which is a home telemonitoring platform that we have here in Galicia, the tracking of these patients, because there are some benefits. With this intervention, we would like to guarantee their care in situations of confinement, reduce the number of face-to-face appointments, follow-up consultations and hospital admissions, and prevent them for traveling to health centers to avoid the risk of unnecessary infections because they are really fragile patients. But we have a barrier here, and it's the high cost of the equipment that is needed to monitor these patients. Next, please. So we ask, how can we finance this intervention, these devices? We are three main stakeholders: ATHIS, which is our organization, and we provide training for patients or families or caregivers and healthcare professionals to use the tool and use the devices. We have Sergas, which is the healthcare provider in Galicia, which provides the telemonitoring tool and its maintenance and the staff that is in charge of monitoring these patients. Then we have the Galician Cystic Fibrosis Association that is in contact with CF patients. They are aware of their issues, and they also provide complementary services as the ones that I put there: respiratory physiotherapy, nutrition, and a lot more. And in our last meetings, we are thinking about one more possible stakeholder, which is a foundation who would be willing to put money in this project to buy these devices. Next, please. So as Alison said, what benefits do we have from participating in Invest4Health? We are looking for new funding possibilities in the field of health. There's a creation of collaborative spaces that enable different actors to express their views. We have expert partners which give us advice and guidance. We can innovate in health by putting the focus on the patient, which is one of our main focus, putting the patients in the center and empowering them and giving them the principal focus. Also, we put the focus on prevention rather than in the treatment of complications. Adding these patients to the telemonitoring tool could give us prevention data of future exacerbations, so we could prevent them from getting, for example, antibiotics or a treatment that would be worse. And we can anticipate future trends in healthcare. Next, please. About our next steps, we need to have conversations with the new possible stakeholders. As I said, we are thinking of that foundations, not profit organizations, to put money in our project. We want to start testing the action. We want to start a small pilot with 10-15 patients because the association has already bought the equipment for those patients. So we could start testing and see the results, if it's good or not, and also present them to these new possible stakeholders. And then as the last step, evaluate the results. And we have listed some indicators that we could use as satisfaction surveys to both to health professionals and patients, families, or caregivers. The improvement in the quality of life of the patients, families, or caregivers, the adherence to the treatment, economic savings, because if they are treated at home, there's a saving in the because they don't have to go to these hospital or primary care centers, and also a reduction of transfers to medical centers, because with this telemonitoring tool you reduce all of this traveling and also hospitalizations and all related with hospital care. So that's a little summary about our testbed. Sorry, and hope you had a good view about it, and hope I explained well. Thank you.
Yes, thank you. Thank you so much. Sorry. I didn't mean to cut you off, Beatriz. Thank you. It was excellent. So indeed, and it is interesting because you'll see in the different examples, and we'll travel to Wales next, but I would say this is the closest to a tertiary prevention and the closest to what is the, let's say, the traditional health system and approaches. But it is nice to note indeed the intention to reduce comorbidities that you might have from getting infections through hospital visits, and also just helping to improve the quality of life of both the patients and their caregivers, and how that can be health promoting in its own right. So thank you so much, Beatriz. Could I now hand the floor to Gareth, who's presenting on behalf of Wales and Hywel Dda, specifically West Wales.
Yep, thanks, Alison. My name's Gareth Davis. I'm a clinical scientist from Hywel Dda Health Board. I'm going to talk about the West Wales test bed. Next slide, please. Yep, so in our test bed, we're looking at combining 3 existing services: diabetes prevention program, national exercise referral scheme, and social prescribing. Currently, all the 3 schemes exist as separate entities, but we're looking to combine the 3 as part of our test bed offering. With the main aim being to reduce the number of individuals going from risk of developing diabetes to fully blown type 2 diabetes. And we are implementing this in the Carmarthenshire region of our test bed, which is roughly the same size of population as the other 2 regions in Pembrokeshire and Ceredigion. So we have quite a nice potential comparator to see what the impact of this intervention is. Next slide, please. So the issues that we have in West Wales at the moment, like lots of the Western world really, is type 2 diabetes is increasing in incidence. It's a major problem. The cost of that is around 10% of the overall budget for healthcare in Wales, and it's almost entirely preventable. The uptake for the current diabetes prevention program, well, it's low, but a part of that is down to capacity. We have the national exercise referral scheme, but there is limited budget for individuals to be enrolled in that scheme, and limited funding generally for prevention limits what we can do. So as part of our solution, we're looking at offering social prescribing as an additional capacity building service, I guess, because they have free capacity in that area. And we're coordinating resources through community hubs also, and using digital as another way of trying to increase the capacity. And we're looking at community social investment to continue to fund the programs. So this could be through local businesses, which social prescribing could signpost to, or clubs, which are already existing in the community, so no further funding required. Next slide, please. This is the pathway we developed with our stakeholders. So the top part is where the patient comes in. They see the health and wellbeing facilitator. This is all through primary care. They're offered various services. These are all people who are at risk of developing diabetes, and they're offered various services. If they're not suitable for any of the initial diabetes prevention interventions like the NERS, the food-wise, then we offer them social prescribing. Additionally, at the 6-month review point, we offer social prescribing as well as part of the intervention, because a lot of these interventions are quite short-term, 16 weeks, 8 weeks. So the plan is to give them long-term options so they can stay on top of their health. If it's something they enjoy, like that is social in the community, then they're more likely to stick to it. Next slide, please. So there's various different funding streams in this project. There's the NHS Wales, Local Health Board, the local authority, so the council funds the national exercise referral. There is Welsh Government local business donations. So just briefly, it's a very diverse funding portfolio, I guess, that goes into this project. Next slide. What are the benefits that we found from participating in this project? It's been very interesting to get the perspectives of people from across Europe. It's been very reassuring that we share a lot of the same problems, and discussing these issues has allowed us to think of more creative solutions and how we can tackle these problems. So that's been very, very useful. There's a broader resource pool, so we've got access to expertise to this project that we don't have in our other, particularly around the finance and the economic aspects. So it's been very useful to have access to those resources through the project. There's a lot of opportunities to collaborate, stakeholders from all across Europe, and this can lead to collaborations on other projects and opportunities such as potential funding, etc. And also the last one, scalability and global impact. So a major problem we have in Wales at the moment, we have pilotitis, everything's a pilot, and we need to start working towards making sure that these interventions actually are scalable and they're actually sustainable longer term. So that's something we're hoping to work through in the project and ensure we achieve that. Next slide, please. So our next steps, we are collecting data at the moment. People are going through the pathway. We have some issues with IG, but we're working through it so we can share the data with our partners in Invest4Health, so we can do a proper evaluation of what the impact of this intervention is, what the impact of the smart capacitating investment, how it's affecting individuals in Wales and the wider health system. So we're just monitoring the pathway at the moment. We've got regular meetings to see how many people are coming through and how it's going, and if there are any barriers or things to troubleshoot, we're working through those. But that's just a summary of what we're doing and what we plan on doing. Thank you very much for listening.
Thank you so much, Gareth. That was very informative indeed. So quite a different approach, but I think that it's nice to see what Invest4Health, what fits under this very big umbrella that we've started to build here. So in the interest of time, I'm going to go directly to our next colleague, who will be Carol, who's going to be presenting to us about what they're working on in Germany, which is Again, quite a different focus than the other two we've heard.
Thank you, Alison. And hello, everybody. I'm Carol Puskus. I'm representing the North Rhine-Westphalia testbed from Germany. And we have been involved in the Invest4Health project from the beginning. And I'm very excited to share with you our progress, our learnings, and how Invest4Health has helped us. Next slide, please. First, I want to give a little bit of context of what is going on in North Rhine-Westphalia. We are focusing on a primary intervention. That means that we want to prevent people from at all getting some illness, and our focus group are people who are working from home. We decided to do this since in North Rhine-Westphalia we have about 18 million people residing here. This is Germany's most populous federal state. And out of this, around 10 million people are employed. And out of these 10 million people, a lot of these are around 64% of the employees now work in hybrid roles, and 24% more or less even work entirely from home. And the trend seems to be increasing. So this is something that is going to happen more often with the time if we continue with this trend. However, this transition comes with some challenges. Many remote workers suffer from physical complaints such as back, head, or joint pain due to suboptimal ergonomic setups. And from the research that we have conducted, we learned that around 66% of the workers report having these issues. And we see that targeted prevention could reduce treatment costs by around 27%, or those are one of the estimations that we could find in the research. Next slide, please. As I said before, our intervention focuses on improving home office ergonomics to support both physical and mental health. I mean, especially the physical health, but we assume that through supporting physical health, we're also gonna have some positive effects on the mental health. We aim to promote long-term health prevention through tailored solutions that address these challenges. This includes the developing of a bundle of services to improve ergonomics. This bundle of services should work through a business model, which we are also trying to develop among the test beds. And we, of course, want to explore the smart capacitating investment, or the SEI, as the innovative funding mechanism. Next slide, please. So especially for those who may be interested on participating on Invest4Health, I wanted to tackle on how Invest4Health has helped us, or how we have benefit from Invest4Health. And I think as I saw the training proposed by you, Alison, I thought like, yeah, that's fantastic. Actually, those are all the points, like how we have get some support from the team. Invest4Health has given us a platform through which we can engage stakeholders and collaborate with many other different actors from our region, because the health sectors combines different persons and different organizations, etc. But also because of the financial model that we want to work with, the SCI model involves also different kind of investors. So it gave us a platform, but through different exercises such as stakeholder mapping, the problem tree, we were able to align our stakeholders and our activities to envision further health trends, and to see what is a good fit for our testbed. The testbed development has also benefited from collaboration with other testbeds, since the ones we are presenting here, we are 4 testbeds in total. And we have also like regular sessions where we can share insights and share the different challenges, because we are very different testbeds, but sometimes we have very common challenges, and it's a very good way to help and support each other. And lastly, the strategic guidance that we have gotten from the project has been very valuable. It has enabled us to identify our problem and to align with the project goals, and to understand and try to apply the SCI model. Next slide, please. Yeah, well, for the next steps, we want to deepen our stakeholders' engagement and collaboration, and align their interests with our testbed objectives, especially. We also are now starting to we are developing some interviews that we start conducting with our citizens, and next year we are going to do these interviews also with stakeholders to identify what are their key incentives, but also what will be their barriers when it comes to participate in such an intervention or such a model. We want to develop a framework, a financial and governance framework that could work for North Rhine-Westphalia, and we want to create a platform prototype that could like demonstrate how we envision the bundle of service with the different stakeholders and users. Yeah, that's my overview. I have many more things to say, but I think I want to keep it short. So thank you everybody for your attention.
Thank you very much, Carol. That's very helpful. And what I do hope we can do, again, with prospective interested partners going forward, is have more, just as we have the deep dives already now in the project, get into more details with incoming, hopefully, testbeds, and discuss in more detail all these great things that you've shared. So now, as before with Lars, last but certainly never least, I'd like to have Bengt present to us about Region Skåne and your intervention, please.
Yes. Next slide, please. The first slide, it presents some facts about the region, and there are only the 2 last bullets on that slide that you have to pay attention to right now, which indicates that when we talk about health promotion and prevention, we meet a rather fragmented context, even in a small province like Region Skåne or like Skåne. We have the regional level being responsible for healthcare, and then we have the 33 municipalities in these rather small areas that are independent and responsible for welfare and social services. So these are the prerequisites we have to do when we are going to implement any type of intervention. Next, please. Our target is different from the other 3, and we target children and young people. We work both with promotion in terms of the well-being part. We have a specific focus on mental well-being for the target group, which is an issue in our area. And we try to do this with what we call for early stage coordinated interventions. And with those types of interventions, we mean that we try to implement, say, more universal health promotion interventions. And in parallel to that, we also implement ability to make low pressure detection of individuals or group of individuals that are at risk, such that we could put coordinated support for the children, young people, and their resources, for example, their parents and schools, etc., into place. and do this as early as possible and on low threshold notifications, basically. Currently, we have quite a few interventions up and running, and they are co-funded by the regional and the municipality and on tax money. But we are looking into different types of financing sources, of course. Next, please. So this illustrates that we have a portfolio run by the municipalities at the lower part of this figure with interventions. We are looking to find efficient means on how to implement different types of pooled and share resources, such that we improve our capabilities to plan for, implement, and scale interventions in general for children, young people during their life course and first 20 years of life. Next, please. Well, what has Invest4Health to help us with? Of course, to look for other types of financing sources, and also how to adapt the concepts that you have heard of today to our specific setup and interventions. We have a problem when we work together with a healthcare system, and that is that to ask for support from other actors in the society. So that is something that we benefit from, that if we could improve our capabilities to collaborate, then we could also invite actors that represent other types of competencies or resources. Next, please. And finally, say that we basically suffer the most, I guess, from difficulties to measure. And this was also brought up when we talked about investors and their preparedness to invest. And these capabilities to improve, how do we measure, how do we evaluate, what data do we have available to convince investors that it's a good business case to invest in promotion and prevention, and in particular to invest in children and young people. Thank you.
Thank you so much, Bengt. That was excellent. And I really, I mean, every time I see all the 4 test beds together, I see again the breadth of what it is we're trying to achieve, and it's very ambitious and it's very novel, and it's great to see now all of, that we've reached the midterm and we are where we are. And I think there's still so much ahead of us in the next 18 months, but I'm optimistic that we're finding good, solid common ground, and we're going to start really addressing some of those next steps that each of you have identified. So we are over time. If there's any urgent question, feel free to ask it. Otherwise, I just wanted to put up the very last 2 slides that we have, which are essentially just to encourage you to please let us know if you'd like to be contacted with further information about the open call that Theo has described. We'll be very happy to be in touch with you, or if you know maybe you're a representative of a network and not of a region itself. If you think that there are others that you would be relevant for us to be in contact with, please get in touch with us. We'd be happy to talk to you, talk to others that you think could be interested. And I did just want to say you can follow, we have a newsletter, so please feel free to sign up for the newsletter, to follow us on social media, our website. So voila, conclusions and next steps. Feel free to leave contact details if you'd like more information. And then just the final slide, I wanted to show our consortium. I think it's one, there we are. So many people have been behind this, and it's been a tremendous team effort. And I just wanted to make sure that even for a moment, everybody got their logo up on the screen, and it was the chance to say thank you to them, but also thank you to all of you who have participated. And we really hope that, again, this is the first of a series of conversations, and we can take forward our next steps together.